Good morning, everyone. Welcome to the panel on medication-assisted treatment for justice-involved populations, so people, excuse me. My name is Taleed El-Sabawi, and I will be your moderator for today. I am an assistant professor of law at Elon University, School of Law. I'm also a scholar at the Addiction and Public Policy Initiative at the O'Neill Institute for Global Health at Georgetown University Law Center. We're just going to give everybody a moment today to log on in, and then I will be introducing your panelists. We will hear from 4 panelists tonight, and if you could hold your questions till the end, we'll have a question and answer session at the end. Alternatively, you can post the question and answer in the question and answer box on Zoom, and I will field the questions at the end. Hopefully everybody has had a chance to log in to the panel, to the Zoom link. So I will go ahead and get started by introducing your first panelist today, and that is Assemblymember Linda B. Rosenthal. Assemblymember Linda B. Rosenthal represents the 67th Assembly District and serves as chair to the Assembly Committee on Social Services. In her time as chair of the Committee on Alcoholism and Drug Abuse, she introduced legislation to authorize overdose prevention centers in New York, to expand access to medication-assisted treatment, and naloxone statewide. She's also required state and local correctional facilities to provide people who are incarcerated with access to medication-assisted treatment, while working to destigmatize addiction issues and expand access to treatment and recovery services statewide. Welcome, Assemblymember.
Thank you so much, Taleed, and good morning, everyone. I'm happy to be here. And I want to thank the Rockefeller Institute for hosting today's drug policy conference and for inviting me to participate in it. And I'd also like to thank my fellow panelists for their contributions in this area and for participating today. I'm currently the chair of the Committee on Social Services, but I was the chair for 5 years of the Committee on Alcoholism and Drug Abuse. This panel discussion really couldn't come at a better time, because just last week, along with some of my colleagues in government and advocates from across the state, I beamed with pride as my legislation to require all state prisons and local jails in New York State to provide people who are incarcerated with access to medication-assisted treatment, along with a comprehensive plan for re-entry into society, and it was signed into law by Governor Hochul. The bill signing, which was held at John Jay College in my district, was the culmination of years of hard work to advance this legislation. But more importantly, perhaps, it was the culmination of years of hard work to destigmatize addiction, ensure that we approach substance use disorder from a public health perspective, and employ a harm reduction approach to treat it. When I first became chair of the Committee on Alcoholism and Drug Abuse, a name that I think needs to be changed because it doesn't reflect the way we talk about these issues today, I embarked on a months-long quest to meet with providers, survivors, advocates, and family members from across the state to learn as much as I could about addiction and the needs of the sector and the providers working within it. It was clear to me from the outset that the overdose crisis was not one that the state was interested in prioritizing. At the time, the budget for OASIS, which is the New York State Office of Addiction Services and Supports, was barely keeping pace with inflation, and providers statewide were struggling to deliver supportive services to the growing number of families who were struggling with substance use disorder. Each group I met with told me the same story, that despite the overdose numbers increasing year after year, little was being done to provide people with access to life-saving treatment. These advocates were some of the most committed and passionate people I had ever met. Many of them were in long-term recovery themselves or had witnessed a loved one struggle with substance use disorder. As a result, they approached the issue in a way that was, for many at the time, unique. Addiction is not a choice, it's a public health crisis. And every overdose should be viewed as a policy failure, a death that we could have prevented if only we had provided the necessary resources and employed harm reduction strategies that were proven to work. It was in these meetings that I first learned about medication-assisted treatment. I was already familiar with methadone, buprenorphine as drugs that people use to, quote, stay clean, but I wasn't aware that those drugs, along with naltrexone, were part of a class of harm reduction tools designed to help people lead the life that they chose, not that the one that was imposed upon them by their illness. Medication-assisted treatment was revolutionary to me and to others in New York State who were not personally affected or even knew people who were struggling. We have a class of medication that is proven to help people stop using drugs and prevent overdose. And despite that, it was clear that the people working in the agency overseeing this area, that the state wasn't doing enough to promote their widespread use or accessibility. To a certain extent, that continues to be true to this very day, hence the need for me to pass a law mandating medication-assisted treatment in prisons and jails. But back then, OASIS was still promoting an abstinence-based model of care for people struggling with substance use disorder. Treatment providers receiving funding from the state were counseled to wean people off MAT. And it was widely believed that reliance on MAT was a continuing addiction. It wouldn't be until 2020 that OASIS would adopt a harm reduction approach with medication-assisted treatment as the standard of care for treating substance use disorder. In addition to the stigma that surrounded substance use disorder and medication-assisted treatment, we were also contending with the vestiges of the failed war on drugs. For far too long, addiction was viewed as a crime. If addiction is crime, it's not even a question that incarceration is the answer. So for years, we locked up people who were struggling with substance use disorder instead of providing them with treatment. And of course, the people who were locked up and the key to their cell thrown away were disproportionately people of color, members of the Black and brown communities who have been decimated by the failed war on drugs. As a result of these short-sighted policies, today it's estimated that more than 80% of people who are incarcerated in New York State prisons or jails struggle with a substance use disorder for which MAT is indicated as an effective treatment. Despite that alarming number, however, only 20% of state facilities and less than half of all local jails statewide currently offer access to any form of MAT. And of the ones they do, they only offer access to limited medication-assisted treatment, in many cases, a one-time dose of Vivitrol just before release. Overdose rates among formerly incarcerated individuals are sky high, and people who've just been released are more than 40 times more likely to die of an opioid overdose than the average person. Without treatment during incarceration to address the underlying addiction, when someone is released, they will go right back to using, usually at the same levels they were prior to their incarceration. Because they haven't used in the same method as before, their tolerance is decreased and they end up overdosing. In part, the inadequacy of existing jail-based MAT programs is a result of the state not providing adequate funding to state and local correctional facilities to implement robust MAT programs. Prior to 2020, the state provided no money for MAT programs in prisons and jails. In 2020, I succeeded in including $3.75 million in the state budget to fund a jail-based substance use disorder program. In 2021, I secured $8.75 million in funding for local jails and $11 million for state facilities for jail-based substance use disorder programs. The pilot, albeit small, helped to demonstrate how well the MAT program could work. But even with the funding available, some local facilities refused to implement an MAT program because they didn't think jails should provide that type of treatment, or the local law enforcement official felt that they didn't want to, they just didn't want to be bothered. It was clear that a voluntary MAT program would not work. You can't have people who are incarcerated get or not get access to life-saving treatment based on where they are arrested or locked up. Along with advocates from a variety of organizations, I fought for 5 long years to see my legislation become law. And now that it has, it will require every state prison and local jail to provide access to MAT. Facilities will be required to screen individuals when they are incarcerated and on an ongoing basis to determine whether they are struggling with a substance use disorder that would be helped by MAT, and of course, whether they are willing to participate in such a program. A specialist must work with the person to design an individualized treatment plan that includes access to the form of MAT that is most effective for treating and meeting the person's needs, along with an appropriate level of counseling. Participation is voluntary, and though it must be offered, it may not be required for an individual. Facilities are not permitted to punish anyone for refusing participation or for relapse, which was a major point of contention among people who still did not understand the nature of addiction. For treatment providers, it's clear that relapse is part of the recovery process. People often relapse multiple times before ultimately succeeding in their recovery journey. In that way, relapse can be likened to a cancer that resurfaces after a period of remission. Despite that, there was a sense that prisons and jails should have the ability to punish participants for a relapse. Incarceration is punitive, so I guess that's the natural inclination. But what purpose does punishment solve in these circumstances? Punishment won't prevent relapse, but it could discourage incarcerated individuals from participating in a program that has the potential to make them well. So we worked hard to ensure the bill doesn't allow for any consequence beyond counseling under these circumstances. The bill also requires facilities work with people in advance of their release date to ensure they are connected with community-based providers and resources to ensure they have the support they need to continue their treatment once they're released. The reentry planning required by the bill ensures that people have access to at least 1 week's supply of drugs and ensures that an individual who communicates a relapse to a parole officer will not be reincarcerated, but will instead be directed to a treatment program. Legislation that was just called up by the governor, which I expect will be signed, will require state and local correctional facilities to provide an annual report to the legislature about the types of substances people are struggling with upon incarceration and a variety of other metrics, so we can better tailor the program to the needs of the incarcerated population as we move into the future. I'd argue it's akin to cruel and unusual punishment to deny a person who is incarcerated access to a life-saving drug that is proven to help ease withdrawal symptoms, limit cravings, prevent relapse, and stop fatal overdoses. And it would seem that a handful of courts might agree with me. There's a growing body of precedent here in New York and across the country to support that. In all the cases, a person entering custody who was ready on MAT was being forced to go through withdrawal because MAT was prohibited in jails. The plaintiffs in each of these cases were all maintained on MAT drugs before being incarcerated and were terrified of the pain of enforced withdrawal and the increased opportunities for relapse and overdose as a result of being forced to stop taking their medication. They argued that denying medication-assisted treatment violated the Eighth Amendment's prohibition on cruel and unusual punishment and the ADA, and for the most part, these cases have been successful. In 2019, a federal appeals court in Boston upheld a lower court ruling that the Aroostook County Jail must provide a woman with medication-assisted treatment for her substance use disorder while she serves a 40-day sentence. Right here in New York State, just last month, in a case brought by the New York Civil Liberties Union, the U.S. District Court for the Northern District of New York issued an order preliminarily enjoining Jefferson County Jail from stripping plaintiff PG of life-sustaining medical care for opioid use disorder. The decision, the first of its kind in the Second Circuit, found PG likely to succeed on claims that the jail's blanket ban on methadone treatment is discriminatory and unconstitutional. Prisons and jails have raised concerns around safety and in particular diversion. These are legitimate concern, but the thinking goes that if you provide people with access to the drugs they need, they will be much less likely to smuggle the drugs in. Will diversion still go on? Of course, but even the courts have found this is not a good enough reason to deny incarcerated individuals access to medication-assisted treatment. By providing access to MAT to people who are incarcerated, along with counseling when necessary and a plan for smooth re-entry back into society, we will save lives, reduce recidivism, and along the way, we will probably make prisons and jails safer for all involved. Finally, correctional facilities will treat addiction like any other health condition and provide medication instead of punishment. Struggling with addiction is not a criminal act, nor is it a moral failing. And providing sick people with health care should not be considered a revolutionary act. I saw an article the other day about 2 correctional officers here in a New York facility who were injured during a contraband search. The officers searched an incarcerated individual who they discovered was smuggling Suboxone into the jail. All 3 were injured in a physical altercation that ensued as a result. Suboxone is a powerful MAT drug that combines buprenorphine and naloxone. It has been shown to reduce the incidence of fatal overdose by 50% and also inhibits the intoxicating effects of opioids, thereby preventing some of the cravings. Suboxone, like other MAT drugs, has the potential to be misused, but its potential to save lives should outweigh those concerns. If everyone struggling with substance use disorder had access to Suboxone or another medication like it, it's far less likely people would feel the need to smuggle it into prison. And perhaps those officers would not have been injured in the first place. And that's just it. Providing access to MAT isn't just the humane approach or the approach that's indicated by science or that's now required by law. It also has the potential to make prisons and jails safer for everyone. By providing treatment to people who are struggling with substance use disorder, we can reduce recidivism and decrease the prison and jail population along with the crime rates overall. My bill will take effect we gave them a year to develop all the plans, but they have to start, in my opinion, right away. So the good folks at DOCS and the officials at the county level have time to design the program and not say, we don't have enough time, so we can't do it. It also provides the legislature with the time we need to negotiate a budget in 2022 that provides OASIS, along with DOCS and county facilities, the resources they need to do this job right this year. and every year into the future, and using all the millions and millions of billions of funding that the AG secured through opioid suit settlements. In 2020, New York lost more people to preventable overdose than any other year for which records were kept. This is not an acceptable outcome, nor is it one that we need to accept. Many people are looking for the magic bullet to prevent overdose and save lives. The causes of addiction and overdose are myriad and complex, but the solution is not. We must treat substance use disorder like the public health crisis it is. We must mobilize a public health response designed to meet and treat people where they are, even if they are in prison or jail. And we must adequately fund supportive services and the organizations that provide them. My next goal is to pass legislation to create OPCs here in New York State. We had the opportunity to be first in the nation. There was a lot of hesitance on the part of the administration, and it did not go forward. But something other countries have known for decades is that OPCs create an environment where no one has to overdose and people can access treatment and care when they are ready to do so. So look out 2022, we're going to pass that into law. I'm thrilled that my MAT bill became law, and I am thrilled to continue working with stakeholders at every level to ensure that it will be implemented quickly and efficiently. Thank you so much.
Thank you, Assemblymember, for that wonderful summary of your work. Just wonderful work that you've done. Okay, so we'll be moving on to our next panelist now, Dr. Erkmen Aslim, who is an assistant professor of economics in the Seidman College of Business at Grand Valley State University. Aslim's primary substantive field of research is applied microeconomics, with a special focus on health economics, labor economics, and public economics. His research mainly focuses on the impact of public health insurance on healthcare and on labor markets, health outcomes, and criminal behavior. Dr. Aslim will be presenting on access to substance use disorder treatment during COVID-19, implications from reduced jail populations.
Thank you, Taleed. Let me share my screen. Can everyone see my slides? Okay, perfect. Thank you so much. Thank you for the Rockefeller Institute for organizing this conference. I'm excited to be here. I'll be talking about access to SUD treatment during COVID-19. This project was actually inspired by a previous research that we have conducted with Murat Mungam from George Mason University, Antonin Scalia School of Law, and my other co-authors looking at the impact of Medicaid under the Affordable Care Act on access to SUD treatment, as well as recidivism. So in my presentation, I'm going to present results from both of our projects, this project that specifically looks at the COVID-19 period, and also policies that were enacted prior to COVID that can be useful during this period, which is the Medicaid expansion. So let's start with some statistics about incarceration, about local jail populations. So the first statistic is that there are 2.3 million people who are incarcerated each year in the US. And 1/3 of this population is confined in local jails. If you look at the DSM-4 criteria for drug dependence or abuse, 2/3 of these inmates in local jails meet this criteria. Now, the relevant question here is what happens to access to drug treatment while these individuals are incarcerated? Well, the statistics are not very positive in the sense that we don't have a full take-up of care during incarceration. In fact, 40% of women and only 50% of men access drug treatment programs while they're incarcerated. And in fact, previous research shows that high quality in prison care can reduce recidivism, and it can also reduce the prevalence of addiction. Now, what happens when these individuals are released from prison or jail? We have to note that these individuals are overwhelmed because they need to find secure housing, they need to find work, they have court-ordered obligations, and they might not even think about accessing certain types of treatments. And when we think about treatment for substance use disorder, the first thing that comes to our mind is medication-assisted treatment, including methadone and buprenorphine. But we also have to mention cognitive behavioral therapy as a successful treatment for SUD. But if these individuals don't have access to health insurance, they have to pay it out of pocket. So let's look at some of the preliminary cost estimates from the National Institute on Drug Abuse. If we include medication and medical services, the cost comes up to $6,552 per year. So is this high? Is this low? Well, let's put these costs into context by using annual expenditures in 2014 for diabetes and kidney disease. For diabetes, the annual cost is around $3,500. For kidney disease, it's around $5,600. So clearly, when we include medication and medical services for substance use disorder treatment, it exceeds some of these chronic health conditions, accessing treatment for chronic health conditions. So what is the bottom line? The bottom line is that inmates return home without proper access to medication or without any care coordination. In fact, 8 to 10 months after release, 25% of former inmates who have been classified by the DSM-4 criteria receive SUD treatment, right? The goal is to increase this percentage to 100%, but it's currently way below that. And perhaps more importantly, over 2/3 of these inmates recidivate within 3 years of release, and about 30% of returning inmates report recent use of illegal drugs. Now, I want to shift some gears and I want to look at how COVID-19 affected local jails. Well, we have this figure. The data comes from the public safety lab at NYU. They have been collecting data on the number of individuals in local jails. So if you look at the number of individuals in local jails, there's a clear drop after March 16th, and March 16th is the date when White House released its COVID-19 guidelines. So there's a clear jail decarceration. There was a reduction in the number of individuals being released. And this could be due to either jails lowering the bar for releases or enhanced requirement for detention. But we wanted to break this data. So this black solid line is everyone, every state is included. But let's look at states that provide Medicaid. We'll call these Medicaid expansion states, those that expanded under the Affordable Care Act. That's the dashed line. And then the solid line is for states that decided not to expand Medicaid under the Affordable Care Act. And the striking part of this figure is that we don't necessarily see a huge difference in the drop between non-expansion states and expansion states. And we have to note that in non-expansion states, some of these inmates might not qualify for health insurance. So now the question is, why did these jails release all these inmates? Well, if you look at the spread of COVID during the first wave, recent studies have calculated the reproduction ratio of the virus, and they found that it was huge in urban jails. And in fact, the reproduction ratio was 8.44, meaning that eight inmates contracted COVID from just one of them. And we can try to understand why this was happening. It's important to note that in local jails, there's a constant flow of detained people and staff. You have a huge turnover, and inadequate testing also contributes to this. And a follow-up study actually looked at what happens to daily COVID cases when these individuals were released from jail. And the study found that 80% reduction in the US jail population resulted in 2% reduction in daily COVID-19 case growth rates. That's a huge number if we look at the total number of cases daily in the US, right? So we kind of understand the justification behind this. It was to prevent the spread of COVID in jails. And the concern was whether these individuals, when they're released, were they gonna take this virus to their communities and contract it there? Well, this study says no. But our problem with this approach was that there should be some checklist when these individuals are being released to their communities, because when these individuals are released, some of them have addiction problems, and without any checklist, they're not going to access care and they're likely to recidivate. And some of the problems that we identified during COVID-19 relates to potential constraints for released inmates to access SUD treatment. And some of these constraints include Medicaid enrollment, right? I showed non-expansion states, right? Some of them might not qualify in non-expansion states, but we also have to look carefully in expansion states because these individuals might be eligible. So we really need a staff to help them out and help them enroll in Medicaid. So that could be one potential constraint when these individuals are immediately released without any connection or without any enrollment into Medicaid. And then disruption of continuous SUD treatment is another constraint, because some of these individuals have access to SUD treatment while incarcerated, although it is not perfect. But when they're released, this could go down to zero. They might not have any access to SUD treatment. And the third constraint was individuals were reluctant to seek in-person care during the pandemic. In fact, there was a 40% decline in emergency department visits, including visits for SUD withdrawal during COVID-19. So what are some of the reasons for that? Well, some individuals had fear of contracting COVID-19, and there were enhanced preventative measures required prior to an admission. Those were also seen as barriers, such as phone screening, physical distancing, etc. And then another problem was a capacity problem. If inpatient and emergency departments near their capacity, and if we take into account the misplaced stigma for these individuals, then this increases the risk of deprioritizing care. Well, when we first wrote this paper, we did an extensive research on whether capacity was in fact a problem, because as economists, we really tend to impose a demand and supply framework to most of the issues. So we really wanted to see if the supply was a problem or whether the problem was happening because of demand, people not accessing care. And we interviewed physicians. We also looked at ongoing interviews, and their explanation was that they had no capacity problems. Capacity was available and that access was the primary problem. However, now I'm continuing my research on this. I see that capacity is becoming a problem in the aftermath of COVID-19 as nurses drop out of the labor force or they just leave their jobs because of burnout during COVID-19. So I think we cannot completely disregard this fact. And hopefully in later, I can also share my result about capacity constraint. We are currently working on that project. And most importantly, absent the points that I have just mentioned, we might see an increase in social costs in the form of future offenses. In other words, if these people don't have access to Medicaid, if they can't access SUD treatment, or if they just decide to not go to the hospital, even though they have health insurance, this can increase their likelihood of recidivating. Now, this is the other study that inspired us to write this paper. And this one is currently forthcoming in Journal of Policy Analysis and Management. In this paper, we said, well, we have this public policy, the Affordable Care Act's Medicaid expansion. Let's look at how this policy affects SUT treatment by payment methods. And also let's look at how this impacts recidivism. If you look at the year, just the year before ACA's Medicaid expansion, most states expanded around 2014. After 2014, we don't see a change in access to SUD treatment among those who have private health insurance. But let's take a look at Medicaid, because the purpose of the policy is to increase the take-up of Medicaid. Well, we clearly see an increase in the number of individuals accessing SUT treatment after the Medicaid expansion. And we specifically looked at those who were enrolled into Medicaid. More importantly, we looked at criminal justice referrals after the ACA's Medicaid expansion. So conditional on having a Medicaid, criminal justice referrals to SUD treatment increased after the expansion. And also, we even disaggregated criminal justice referrals. We looked at those who are in prison, those who are on probation or parole, and referrals to SUD treatment increased among those who have Medicaid. And then finally, we wanted to look at what happens to recidivism, right? So the hypothesis here is that recidivism is going to be impacted through access to treatment, through access to SUD treatment. And clearly, we see a decline. After the ACA's Medicaid expansion, one-year recidivism, especially for violent crimes, and these crimes tend to be committed impulsively. So if you look at the psychiatry literature, oftentimes violent crimes are correlated with impulsive behavior and mental health problems, as well as addiction problems. So we see a clear decline after the Medicaid expansion. Now, you might be wondering, well, okay, you have been talking about the impact of Medicaid on recidivism, but tell us about the costs, right? Because that's often a counter argument. Well, it's very costly to have public health insurance, right? Especially there's an ongoing debate right now about Medicaid, Medicare, and all this stuff. So sure, let me provide you some cost estimates. We did a partial cost benefit analysis. The blue bar shows 1 year recidivism, averting recidivism within a 1 year window. And then the red bar shows averting recidivism in a 2 year window, right? We can extend these windows, but I'm just going to illustrate these two for now. And if you look at the 1 year cost of providing Medicaid, so assuming that 1 year is going to be sufficient enough for these individuals to get treated, right? We clearly see that benefits to cost ratio is greater than 100%, right? So we have a higher benefits to cost ratio within 1 year. We see a slightly lower benefits to cost ratio as we increase the years for an individual being on Medicaid, 2 years, 3 years. But I have to note that we haven't included some of the benefits that are hard to measure, such as the direct value of Medicaid. So there are some studies that actually attempt to measure the direct value of Medicaid. In those cases, this benefit cost ratio increases further. And again, we are currently working on another project to calculate the marginal value of public funds coming from Medicaid. So we are basically trying to do a full cost benefit analysis. Now, based on these two studies, we have come up with 3 important policy recommendations. And this is not only based on our study, but we did a comprehensive literature review on other studies. So our first policy recommendation is enroll individuals leaving jail or prison in Medicaid. especially lift the statutory exclusion on Medicaid reimbursement for services provided to incarcerated individuals. And more importantly, incentivize states with relatively low coverage to expand Medicaid. For example, non-expansion states. And then we have seen that during COVID-19, telemedicine or telehealth for SUD treatment really complemented in-person care, but the reimbursement policies are very complex and it varies by states. So our second policy recommendation is modify Medicaid reimbursement policies. If you look at payment parity between telehealth services and in-person care, it only exists in 20% of states. So the reimbursement rates are different for in-person care and telemedicine services. So that is going to create some issues. In fact, previous studies show that when you have these disparities in reimbursement rates, it can increase spending. When we think about spending related to telemedicine, it can increase relative to in-person care due to this complex structure of reimbursements. We need to notice that given the extensive research on telemedicine, and we need to notice that it complements in-person care and can reduce access problems. And this is not only for former inmates, but it can also help access problems among the general population. And finally, this is our final policy recommendation: connect people to community-based health and social service providers upon re-entry, right? Specifically, coordinate access to SUD care, including medication treatment. We have to take into account that if states enact or if states implement in-reach services, such as having case managers, clinicians, or peer support professionals visiting individuals in jails or prison, this can really reduce access problems and recidivism, because these in-reach services through case managers, etc., will allow these professionals to assess the inmates' health. They can establish relationship with inmates, and more importantly, they can develop an individualized care plan and schedule future appointments. So if we go back to my previous point about how inmates are overwhelmed when they leave prison, this can mitigate some of those problems. And some of these changes and improvements that we proposed in 2020 are currently considered under the Build Back Better legislation. So I guess that's a good news. And I think we still need future research on certain parts of the legislation in terms of assessing the causal effects of these policies, and also doing a cost-benefit analysis like the one that I showed earlier for Medicaid expansion. But we know that Medicaid, the benefits of Medicaid far exceeds the cost. And thank you so much. That's all I have.
Thank you so much, Dr. Aslim. Learned a lot. All right. We have Dr. Benjamin Howell coming up next. Dr. Howell received his medical degree from the University of California, San Francisco, along with a master's of public health from the University of California, Berkeley School of Public Health. He is currently faculty at the Yale Center for Health and Justice and affiliate faculty in the Yale program in addiction medicine. Dr. Howell will be presenting changes in health services use after receipt of medication for opioid use disorder in a statewide correctional facility system. Excuse me. All right, Dr. Howell.
Thank you very much, Professor El-Sabawi. And I would just like to say I really appreciate both the previous presentations from Assemblymember Rosenthal and Dr. Aslim. That hopefully I won't repeat too much of what they've already said, but I will just hopefully add to the conversation. I also really want to thank the Rockefeller Institute for putting together this conference. I think these are really the right conversations to be had about pushing sort of drug policy forward using the best evidence possible. But as Professor El-Sabawi said, I'm going to be presenting on our study that looked at community healthcare use following receipt of medications for opioid use disorder in correctional settings. And just to clarify, I use the term MOUD, or medication for opioid use disorder, in lieu of medication-assisted treatment, although the terms are interchangeable. So just a quick recap, frankly, building off what Dr. Aslim and Assemblymember Rosenthal already said, we know a high proportion of people with opioid use disorder enter our prisons and jails, enter our correctional systems. In a rational system, I think we would be offering all those people buprenorphine and methadone, as well as naltrexone, to treat this medical condition. But unfortunately, as we know, the vast majority of prisons and jails in the United States do not offer these treatments. So what happens when these people re-enter the community? They have not received treatment for their underlying addiction. What we know happens is, unfortunately, a large proportion of them die. The rates of overdose are extremely high following release, and has significantly contributed to the drug overdose epidemic in our state. I know here, or in our country, and I know here in Connecticut, 50% of the people who died in the past year had been in and out of the correctional system. So there's a large role for the correctional system in OUD care. Other issues, and I think Dr. Salim mentioned this a little bit, that we know they end up back in prison and jail. People with untreated addiction and the criminal behavior that goes along with that, unfortunately, means that they end up going back into our prison and jail system. And finally, sort of more closer to what this study was about, we know they end up in the hospital. And really, it's sort of related to their addiction, related to infections related to their addiction, and things related to that for people with their untreated underlying opioid use disorder. Luckily, the situation is changing, and it was great to hear from Assemblymember Rosenthal that New York State is pushing forward expanding treatment to medications for opioid use disorder throughout the correctional system. But Rhode Island, I will say, was a little ahead of the curve there. So in 2016, under the leadership of Governor Raimondo, at the time, passed legislation and added to the budget to increase access to medications for opioid use disorder in the Rhode Island Department of Corrections. And at that time, it was the first state-level correctional facility in the United States to offer MOUD system-wide. I think a couple things just to note about Rhode Island, especially comparing it perhaps to New York State. Rhode Island has a unified prison and jail system, unlike New York State, where there are county jails and a state prison system. So Rhode Island is unified. It's also a much smaller state. And Rhode Island is also a Medicaid expansion state. So there's a couple features that made it, frankly, easier for them to implement there. On the bottom there is the maximum security facility there in Cranston, Rhode Island. And I'd just like to feature Dr. Jennifer Clark and Dr. Jody Rich, who have both been in Rhode Island for a very long time and were champions in implementing this program well before 2016. So they've implemented a medication for opioid use disorder program at the Rhode Island Department of Corrections. I guess it raises the question, what happens to all these outcomes that we're interested in? So they have done one preliminary study where they were able to show year over year a decrease in 60% in the rate of fatal overdoses in people who are in and out of the correctional system before and after they implemented the program, which is not surprising. We know medications for opioid use disorder reduce the risk of overdose by around 50%, but it's good to see that on a statewide level, they're able to show that the number of fatal overdoses decreased by 60%. It's unknown, that I think the studies are still ongoing, how the implementation of this program affected recidivism. And again, sort of it's unknown how it affects healthcare use, whether it's acute care services such as an emergency department or inpatient hospitalizations, or even outpatient services. As we expect, people who are started on the medication might increase their utilization of outpatient services. So we strive to get at this question with this study. So what we did, well, actually just a little bit of background, we know medications for opioid use disorder have a strong evidence that they reduce mortality. In non-correctional settings, there's some good data that initiation of MOUD is associated with decreased hospital and emergency department utilization and increased outpatient utilization. But really there's mixed data on the results on the effect of total healthcare costs. And again, all this previous data is in non-correctional settings, so we wanted to expand on that to see what the impact of this program was. So again, this was our hypothesis that implementation of the MOUD program in the Rhode Island Department of Corrections was going to be associated with potentially, I think honestly, we thought there would be an increase in outpatient healthcare use and potentially a decrease in inpatient healthcare use, but we really wanted to look at that question. And ideally, we were comparing people who were exposed and non-exposed to the program. For various reasons, that was not possible because that would be our ideal situation. So instead of doing this, we compared people to themselves. So people who were before they were exposed to the program and their healthcare use after they were exposed to the program, but we limited to people who had been in and out of the correctional system. To do this, we limit our population to individuals who received MOUD while incarcerated in the Rhode Island Department of Corrections, which was started after 2016, that were in Rhode Island Department of Corrections and enrolled in Rhode Island Medicaid, and that were also previously incarcerated in the Rhode Island Department of Corrections in the years preceding the implementation of the MOUD program, so 2014 to 2016. So we're going to use data before the implementation program and after the implementation of the program. We linked data from the Rhode Island Department of Corrections with the researchers at Brown. We linked that to Medicaid claims data provided by the Executive Office of Health and Human Services in Rhode Island. And again, we compared individual healthcare use after release from Rhode Island Department of Corrections between periods before receipt of MOUD in RODC and after receipt of MOUD in the Rhode Island Department of Corrections. The outcomes we were really focusing on were total per year costs, changes in inpatient days and costs associated with inpatient hospitalizations, emergency department visits and costs associated with emergency department visits, as well as outpatient costs and pharmacy costs. So this was the general plan that we had. To get to our results, so we were able to identify 807 people who met our criteria. So those are people who received MOUD, were in Rhode Island Medicaid claims, and had been previously incarcerated between 2014 and 2016 when they had not received MOUD. The demographics generally make up, sort of reflect the demographics of the Rhode Island Department of Corrections. It was predominantly male, 75%, predominantly sort of middle-aged, 36 years old was the average age. They were predominantly white, non-Hispanic, with a small proportion of Black, non-Hispanic, and other ethnicities and races. Looking at sort of the medications that they received, so I didn't say this before, but the Rhode Island Department of Correction MOUD program offered access to all 3 FDA-approved medications for opioid use disorder. So that's methadone, Suboxone, and naltrexone. And their experience has been that pretty much 50-50 people choose methadone or Suboxone, with a much smaller percentage initiating naltrexone. And then our data kind of reflected the overall uptake of the Rhode Island Department of Corrections MOUD program. I do want to feature that these were people who were incarcerated a lot. Again, this is both prison and jail side here in Rhode Island. But over the 4 years of data we had, on average, people went in and out of the system around 4.5 times, between 4 and 5 times. So this is a pretty high churn population. And the average number of days they were incarcerated over that 4-year period from 2014 to 2018 was 342 days, with a pretty broad range. Again, this is a lot of churn on the jail side, sort of pre-sentencing, people coming in and out, but frankly, spending a lot of time in the Rhode Island Department of Corrections. So looking at costs, so this is really the overall cost that we saw. So this first column is over the whole time period, 2014 to 2018. These are just costs paid by Rhode Island Medicaid, and we adjusted all the costs to 2014 for inflation to 2014 dollars. Over the whole time period, this population accrued $43.5 million worth of Medicaid claims. On average, they had 1,200 days when they were in the community and not incarcerated over that time. So when you break that down, on average, the cost per year for individuals was around $1,600. Before and after receiving MOUD, the total Medicaid cost, you can see there's the Rhode Island Medicaid spent a little bit less, but that reflected fewer days, average days in the community, so that the average per year cost on the individual level was a little higher, although not statistically significantly different. So I would say really no change in the per year cost for individuals before and after receiving medications for opioid use disorder. Looking at some of the different other outcomes, looking at inpatient days, On average, over the whole time period, people were in the hospital for around between 11 and 12 days per year. And before and after receiving MOUD, there really was no change in the average number of days people were in the hospital. 13 before, 11 after. Breaking that down to different types of inpatient hospitalization, those for medical care and those specifically for addiction care. Maybe there was a trend in a decrease in the number of inpatient days for addiction care, but really this was statistically not significant. And then finally, the one positive signal we had from this utilization data was that the number of emergency department visits per year decreased before receiving MOUD and after receiving MOUD, from 3.5 to 2.5 on average emergency department visits per year on the individual level. Breaking down the costs for these 807 individuals, again, before and after receiving MOUD, the total Medicaid claims were really statistically no change, potentially a slight increase on the individual level per year. Breaking down these costs by different claim types. So inpatient claims really did not change per year before and after the receipt of MOUD, for around $7,000 before and after. The cost per ED visits definitely decreased in a significant way. It's not surprising, as we saw the number of ED visits per year go down. But then what made up the difference was actually pharmacy claims and outpatient claims. The cost paid by Rhode Island Medicaid on the individual level per year increased. So pharmacy claims going from around $1,500 per year to $2,500 a year, and outpatient claims going from around $3,000 to around $4,000 per year. And just a quick note on the pharmacy claims, we broke it down by different medication types, and there definitely was an increase in the claims for medications for opioid use disorder, as we would not be surprised. Obviously, claims for buprenorphine and claims for intake in the methadone programs. Other things that we saw, there was an increase in pharmacy claims for hepatitis C medications, which are very costly, but frankly, that's honestly a win. So will cost more, but we're potentially, people are in treatment and being identified that they have hepatitis C and being treated for that, and that's going to lead to an increase in, that led to an increase in some of the pharmacy claims. And yeah, again, so there were some other claims, and just in general, there was really no change before and after the receipt of MOUD in the Rhode Island Department of Corrections. Just to conclude and to give plenty of time for the other speaker and for more questions, what we saw, there was really no substantial change in individual per year Medicaid claims paid for people released from Rhode Island Department of Corrections following exposure to their medications for opioid use disorder program. Really, there was no change in inpatient days or costs, but we did see a decrease in emergency department use and costs associated with emergency department use. And then on the flip side, we saw, which I think is a win, an increase in outpatient and pharmacy costs, specifically pharmacy costs for MOUD and hepatitis C medications. So I think my story for policymakers, for the take home for this, is that if you expand MOUD access in your correctional systems, you can be reassured that you're going to see a decrease in post-release mortality, but potentially with no or at least only a modest increase in Medicaid costs, and shift costs from acute care utilization in the emergency departments to non-acute care in outpatient settings, which I think is an overall good shift in costs for Medicaid programs. Just like to briefly thank the collaborators on this program, Dr. Wong here, Dr. Clark and Dr. Rich, as well as Rebecca Lillo and Rosemary Martin, who are also in Rhode Island. Thank you very much.
Thank you so much, Dr. Howell, for sharing with us that great evidence that really does help support pushes for policy to increase access for medication for opioid use disorder. Thank you very much. Okay, we will be closing out today with one last panelist presentation, and then get ready for questions. So our final panelist is Acting Executive Deputy Commissioner Daniel F. Martello III. Began his career with the then Department of Correctional Services in May of 1997 as a correction officer trainee. In August of 2012, Martello was appointed Deputy Commissioner for Administrative Services, and most recently to Acting Deputy Commissioner for the New York the New York State Department of Corrections and Community Supervision. Boy, you can tell it's Thursday, and we've been having problems using words today, so my apologies. All right, so let's see if Acting Executive Deputy Commissioner Marcitello will be presenting on medication-assisted treatment in state prisons.
Hi, good morning all, and thank you, and sorry for the clunky introduction. Appreciate the Rockefeller Institute for hosting this very important discussion, as well as my colleagues and panelists that have joined us here today. Obviously, a lot of passionate work going into this topic, and very important and critical, particularly as we talk about justice-involved individuals and MAT in a correctional setting. I'm going to share my screen and see if I can get through the technology piece. And okay, so I'm going to talk a little bit about the evolution of medication-assisted treatment in New York State prisons. I'll first start to give you a little background on the department. First, our mission, obviously, to improve public safety by providing a continuity of appropriate treatment services in safe and secure facilities where incarcerated individuals' needs are addressed and they're prepared for release, and then followed by supportive services while they're on parole for a successful completion of their sentence. Our mission has 4 broad policies, one of which is specific to health in general, and that is to provide psychiatric and medically necessary services to those requiring such care and treatment so that each incarcerated individual and parolee can maximize their own state of health and rehabilitation. So clearly within that policy falls treatment of substance use disorder and access to medication-assisted treatment. Before I talk a little bit about our evolution and where we're going with MAT inside of our facilities, we currently operate 50 correctional facilities across the state. We have 37 community supervision bureaus. We employ approximately 27,000 employees. We have 32,000 incarcerated individuals. We're actually slightly below that this morning at 31,800, and 36,000 parolees. To speak to the previous panelist and the decline, I'm happy to say that here in New York, we've seen a tremendous decline in our incarcerated population. This is the lowest level of incarceration in New York State since 1984. Our high was in 1999 at approximately 72,900 individuals. So we've witnessed a 56% reduction in the number of people incarcerated in New York State. And that's really a testament to our values here in New York and really reducing mass incarceration. Here's a picture of the state of New York. It shows the various correctional facilities. So it shows how geographically dispersed our prison system is, as well as it depicts where our regional offices are for community supervision. So in terms of medication-assisted treatment and the evolution that we've gone through here in New York, Bedford Hills Correctional Facility, which is our maximum security facility for female incarcerated individuals, we've been providing MAT through a collaboration with hospitals in that community to pregnant incarcerated individuals within our system for over 2 decades, both methadone and Suboxone. Once the baby was born, we would then at that time wean the incarcerated individual off of the MAT and continue providing treatment within the institution in the form of alcohol and substance abuse treatment. That has since stopped, and we now maintain the individual on the MAT throughout their incarceration. In August of 2014, DOCS became the first state agency to be a certified opioid overdose prevention program, And then we infused in our phase 3 of transitional services, which all incarcerated individuals receive prior to release, education on the risks of opioid overdose. And we actually train the incarcerated population on the use of Narcan. Upon release, we provide or offer each incarcerated individual a opioid prevention kit, which contains intranasal Narcan, as well as provide them a card indicating their training. We further reinforce the ability to have Narcan with the individuals when they meet with their parole officers, so that there's no indication that this may be a violation of their parole, that they could actually have this. We encourage them to have this and utilize it in the community as necessary. In 2016, DOCS worked in collaboration with Oasis to establish a Vivitrol program at our Edgecombe Correctional Facility for parolees participating in that diversion program. And then we launched similar programs at Hale Creek, Orleans parole diversion programs, as well as our Willard drug treatment facility. In 2018, we again re-engaged Oasis and partnered and leveraged our relationship with New York City DOCS in the ongoing MAT program that they were running through their partnership with Health and Hospitals. And we formulated a plan to bring return parole violators who were on MAT either in the community or started in Rikers Island to continue their MAT at the Queensboro Correctional Facility. And that program, again, was focused on methadone and continuing those individuals who had 120 days or less time to serve on a parole violation. We established a relationship with an opioid treatment provider in the community to prescribe the methadone, and then via a guest dosing program where we would send staff from the institution on a weekly basis to the provider to pick up the individual prescriptions of the methadone for the patients. And then we provided the medical services as well as the substance abuse treatment counseling that were necessary inside of the institution. And we leveraged our tele-video equipment in order to do consults with the OTP in the community as necessary, and also site visits to the institution. And then upon release, the individual was transitioned back to the community for continued treatment. In 2019, seeing the success of this pilot program and knowing the importance of MAT and providing and addressing addiction, we expanded the program to individuals receiving MAT in the community or locally that were sentenced to DOCS custody that had up to 2 years to serve. And again, this was an expansion of the program, recognizing its usefulness and the success at Queensboro. We then worked to identify additional facilities, OTPs in the community, to partner with our facilities to offer methadone to those incarcerated individuals to maintain them. We expanded to our downstate and Elmira correctional facilities, which were important because those are both reception facilities. So they handle all of the intake and into our system for the male population. And as I previously mentioned, we already had an established program at Bedford, which is the reception center for our female facilities. We then selected a number of facilities at varying security levels and geographically dispersed across the state to make sure that we were providing appropriate access, getting incarcerated individuals closer to home and not letting their participation be a deterrent, as well as facilities that had a variety of programs to meet their identified needs. So those were both at Cayuga, Marcy, and the Wallkill Correctional Facility. We then, recognizing that obviously methadone was only one of the approved drugs for the treatment of SUD, we then engaged our clinicians in obtaining their X waivers, which from the DEA, which would allow them to directly prescribe buprenorphine or Suboxone. And we then mirrored the expansion of where the methadone was offered. And then we expanded to additional facilities to broaden the services that we could provide to unique populations. Critically was the expansion to the Lakeview Shock Incarceration Correctional Facility, which is a 6-month program which allows individuals to be released from incarceration early and back to the community. In addition, we provided Vivitrol or naltrexone at a number of facilities across the state. As we embarked on this relationship with OTPs in the community, as well as the administration of Suboxone and buprenorphine, it became clear to us that it was critical to engage in discharge planning. We created a unit in central office within our health services that coordinates with the OTP, as well as the facilities, and meeting with the incarcerated individual, identifying the communities they'll be returning to make sure that we can do that warm handoff and that they have a appointment scheduled in the community with an OTP provider, ensuring no break in service and that they have a continuity to their MAT services. Additionally, back in 2013, prior to us really embarking on a lot of the work surrounding medication-assisted treatment, we also began enrolling incarcerated individuals in Medicaid. We start our typical discharge planning, setting aside MAT 120 days prior to release. So we hired 20 Medicaid enrollment clerks. Again, we put them in facilities throughout the system and gave them cadres of facilities that they would engage incarcerated individuals. We identified those people getting ready for release or that had high or had certain diagnostic or diagnoses with our medical providers to enroll them in Medicaid. And I can say that today, current incarcerated, we have 48% of our incarcerated population is enrolled in Medicaid. This is really critical to their release and reintegration into society. That continuity of medical care when they get released back in the community is really critical to their success. And we're really proud of our enrollment process. We did run into some hurdles in terms of Medicaid enrollment when we did some discharge planning. As we were engaging providers with individuals coming out of prison and returning to the community, when we wanted to set them up to transition either to an OTP in the community or other medical services, because it was a suspended Medicaid status here when an individual is incarcerated, when the provider looked in the system, they saw that suspended status, which gave them some pause to, do I take someone in the community that I can ensure payment, or do we take this incarcerated individual to transition and provide services to? So here in New York, we have moved to 30 days prior to release. We activate Medicaid. It's not for billing purposes whatsoever, but it allows the system to indicate that the Medicaid is active, and it's resulted in better outcomes for us being to transition people to providers in the community, particularly as we talk about nursing homes, dialysis, and also OTPs. So really positive step there. And the last thing I'll say about the Medicaid enrollment, and I think it was a good decision we made in New York to actually enroll. There are some states that have a presumption for incarcerated individuals being released, which then they have to go through the enrollment process in the community once released. At the time of discharge, obviously it's a big change for the individual as they re-enter society. A lot of things that they're encountering for the first time or since incarceration. So having them enrolled versus a presumption where they then have to take that on, I think is really critical step. In terms of the bill that Assemblymember Rosenthal championed through the legislature and Governor Hochul signed into law on October 7th, it amends correction law by adding new sections. And I'm not going to go into the details of the law. There's nobody better to cover that than Assemblymember Rosenthal, who gave us a very good overview of what the law requires moving forward. In terms of the New York State budget this year, as the Assembly member indicated, there was an $11 million appropriation to support MAT within New York State Department of Corrections and Community Supervision. There was a separate appropriation as referenced to support local jails to also provide MAT services. So basically, where we find ourselves, DOCS is well positioned based on where we've started and the progress in the implementation of an MAT program to ensure that we meet all aspects of the law by the effective date. We've already begun work and continued our work in the expansion to make sure that we're well ahead of this deadline in terms of implementation of the law. We've begun interviewing incarcerated individuals to identify who had a previous opioid dependency, which will assist in our qualified medical clinician in diagnosing individuals for SUD. As the Assembly member indicated, when we do intake into the facility, we know that we have approximately 76% of our population has a substance abuse need that needs to be addressed. And we offer alcohol and substance abuse treatment in all 50 of our institutions. What we really didn't do was a good job in capturing actually what their dependency was or the substance that caused that need, which is what is critical as we move forward with identifying people with a substance use disorder. And then obviously getting those individuals that are interested assessed by that medical clinician so we can begin to the further evolution in terms of induction. As necessary, docs will continue to engage OTPs in the community to expand our relationship with those individuals. And we're also working with OASIS to apply to become our own corrections-based OTP. Obviously, where our prisons are located, there are some communities that there's just not OTPs available or not in close proximity to our facilities. So we are exploring the option of becoming our own corrections-based OTP and have already engaged the federal government on that initiative. There are some hurdles as we talk about, the expansion and more so in becoming our own OTP statewide. They're navigating the federal regulations that, in my view, did not anticipate correctional systems becoming an OTP, particularly ones as geographically dispersed and as large as New York. Some of those challenges are, can one OTP service all of DOC's facilities? There is some geographic restrictions where we have satellite units under the federal regulations. So, as I said, we'll continue to leverage established OTPs in the community while we continue to work on becoming our own OTP. And then also the storage of the methadone. Currently, as I mentioned, we were getting a week's supply per patient and then storing that individually and providing that to the individual on a daily basis. As we transition to our own OTP, is there a better way that we can bulk store and then dispense via our pharmacies? And then also identifying qualified physician, obviously, to oversee our own OTP. And then lastly, as we do discharge planning and we expand our footprint in MAT, recognizing that incarcerated individuals return to the communities that they came from, where we do induction and they haven't had a prior relationship with an OTP in the community, ensuring that there is someone that we can transition them to and continue to provide services. So, we look forward to, continuing on this journey, the partnership with the assembly member and, those in the administration. This is something, our governor and my Commissioner Nucci, are dedicated to seeing through and really implementing, because, as was said earlier, this isn't a choice. It's an addiction, and it's clearly something that we need to address inside of our correctional system and in society as a whole. And we look forward to in continuing that work and making sure that we're providing the services necessary for people to return to our community and continue to join and live law-abiding lives. So I appreciate the opportunity to present, and I look forward to any questions during the discussion. Thank you.
Thank you so much for sharing what the New York State Department of Corrections has been working on. So we are a little bit behind. Unfortunately, we don't have a lot of time for questions, but if you do have any questions, if you can go ahead and post them in the Q&A. I don't see any currently, but I will give it a moment. And while I am waiting, I'll go ahead and remind you that today is a full day of webinars on drug policy. And at 12:15, we will hear from 2 New York State senators to offer their thoughts and provide a perspective on some actions that the state government is taking to address addiction policy reform. So you can find these links to access the meeting and other meetings by searching the Rockefeller Institute's website and select events from the top of the website. So if you missed any of the presentations today, or you'd like to rewatch any of them, including this one, videos will be up on the Rockefeller Institute's website early next week. So you can visit the website to learn more. Yeah, quiet crowd today. I don't see any questions. The link, it looks like the link is here in the chat if you want to access future panels. But I know everybody's exhausted. It is Thursday, so I'll go ahead and call the session to a close. Thanks again to our amazing panelists for a wonderful panel, and good luck and enjoy the rest of the conference.